co-founders as an operating partner with them. And Carla and I, with Bruce and Mark, Dr. Calderon, been talking about the state of healthcare in Nevada, which is not much different than the rest of the country, but a little worse, in more fragmentation, more dysfunctional. We were one of the lowest cost, at least for a while. Now we're the third most expensive healthcare in the country after Florida and New Jersey. So we lost that. And I will never forget, it was 2007. It was in Johannesburg, South Africa. And one of the foundation that started ranking the states across the country in their quality, cost, access, all this. So the speaker said, "Is there anybody here from Nevada?" And of course, like, "Oh my God, yeah, me." And he said, "You're absolutely the worst. You ranked 51st. And I said, "That cannot be. It's only 50 states." He said, "Well, we also rank Washington, D.C., in the District of Columbia, and you're number 51st. And in every category." So that point of professional embarrassing moment, and I've always put in my head, and I came back and I told the story to Carla and to Dr. Bacchus and some of our physician leaders here. And we worked hard on this during the healthcare partner days, and I think my last day with healthcare partner, we were up to the 35th or 36th state, and I pledged that I'm not gonna retire till we hit 25 or better. So we got about 10, 11 steps to move up. But when we dug deep and looked into the structural dysfunction of the healthcare, I can't even call it a system in Las Vegas. There are a chain of hospitals. There are a bunch of large groups, one owned by an insurance company and other owned by a large health system in Utah, and then multiple small groups left. And for the longest period of time, there was a strange feeling between the hospital and the doctors that they are on opposite ends of the delivery of healthcare, and what's good for the hospital is not good for the doctor, and what's good for the doctor is not good for the hospital. And the one thing that struck me in this end of the conversation, that no one put the patient in the equation. We were talking about the legged stool of the healthcare system being the payer, the hospital, the doctors, and the patient was not even counted in the equation. And we have developed a creed in healthcare partner, which is if you take care of the patients, profit and everything else would follow. And that is the ultimate, if you ask my opinion, my humble opinion, that's the ultimate definition of value-based care. I mean, the word has been, I don't know about damaged, but it's overused and misused and misplaced. Talking about value-based means I'm going to get incentive or whatever it is, but the ultimate value-based it should accrue to the patients. The end users of the healthcare system are the patients. And I will never forget when we were building one of the offices and whatever, and one of the administrator came to show me the office, and she said, and we had a private entrance for years, so you can go directly to your office and you won't be bothered by the patients sitting in the waiting room. And for whatever reason, that term kept, in my head. What made her believe that the patients are a bother? I mean, it's why somebody, an executive in the healthcare industry, think patients are a bother for the doctors, the prince that needs to go directly to. So that's one of the flaws in the healthcare system. We doctors and the people that work in healthcare think that we're doing the patient a favor by seeing them. We're doing them a favor by treating them. And what I've always said, and I always felt, that it's an absolute privilege and honor to be invited in these people's life at the time of need. And if you walk into the exam room or wherever you are with that kind of understanding, feeling, and inspiration, you'll be a great doctor, you'll be a great clinician, a great healthcare executive. And I think we're getting there. The last piece that we needed in Nevada is creating an actual health system. So statistically, we are the largest metropolitan area in the country that does not have a single healthcare system. If you go to Wichita, Kansas, they have two large healthcare systems that's operating through the city. I can go on and tell you all the small cities that has either for-profit or non-for-profit health systems, where the doctors think the hospitals is theirs and the hospitals believe the doctors are theirs. And where the doctors and the hospitals and the payers work for what's best for the patients. We don't have that here. So Carla and I have been talking about it for almost a decade. First, it was a concept of integrating healthcare partner with the Valley Health System, and that didn't work for a while. Then when we started P3, we thought, why don't we build it with Valley Health System? That didn't work out. So in earnest, I think we started about a year and a half ago, talking about building this clinically integrated system of care. And I'm very optimistic, and I believe that we are as close as ever to reach that goal, to have a well-functional, high-performing, clinically integrated network and system of care where we don't look at one another as a competition, but as a collaborator of taking care of the patients. So the first order of business is we try to identify the problems. What are the so for the patients, 1 out of 4 patients says that they cannot get access to care when they need it. Not in the primary care, not in the specialty care, not in the hospital care. They just, 1 out of 4. I'm gonna let this sink in. 1 out of 4 in the most expensive healthcare system in the world, in human history. The patient cannot access care when they need it. And the most stunning was 81%, so 8 out of 10, more than 8 out of 10, will tell you we're sick and tired of filling papers and forms. I experienced this myself. It was the ultimate one that really got me. So my wife got sick a little bit for Christmas, so we needed a CAT scan went to Desert Radiology and sat down and filled 34 pages of paperwork in the morning. After her doctor referred her to there, they don't know anything about her. All what they know is a name and an appointment. Okay, so we filled the paper, and it was abdominal CAT scan. Then when they got the results in the afternoon, they said, oh, there's something in the top of the pelvis. We need a pelvic CAT scan. So we walked in the same day, about 4:30 in the evening, same place, same Desert Radiology office, and the lady in a brave step hand me the 34 pages and say, would you please fill this out? And she just went back at her business. I'm like, we were here this morning. Estelle, fill it out. I'm going to spare you what I did after. But, but it is, I didn't realize how frustrating it is to patients. In the survey, there was an investment banking firm. The analysts did a survey recently. And not only that the patient was frustrated by the time consumed of them filling out the paperwork, but they felt they don't know me. I'm starting all over again. I'm asking the question. Sometimes I remember what I answered before, sometimes I don't. So it is not only time consuming, but it's confusing, and it's building a mistrust and distrust with the providers and the system overall. And back, I think it was 2001, 2002, were hospitalists in 4 or 5 states. And I found our doctors write comments like patient is non-compliant. So I got the group together and I said, we're no longer going to write patient is non-compliant. What we're going to write is I failed to earn the patient trust. Because if they trust you, if they believe in what you say, they're going to do what you ask. But if they don't trust you, it's going to say, it's like my dad used to say, he just sent me there because his cousin owns the CAT scan and he's going to, or whatever. It wasn't until he found a doctor that he trusted and a system that he trusted that he started being compliant. So it is when we fail to earn a patient trust by asking them to fill papers in the morning and refill it in the afternoon in the same office, it's when you completely lose the trust in the system. And if you do, then becomes the next statistics. It was $7.50 was the average copay cost that a patient would change their primary care for. Because you know what? You all suck. So what difference does it make? If I can save up to $7.50, I'm just going to save it. And if a new doctor that I don't know opened down the street, I'm going to save the gas of going across town or whatever it is. I'm going to go see that new doctor. So we put our head together with the Valley Health System and UHS and UMC and some of the physician leaders, and we tried for a change, leverage the technology to resolve these issues because it is resolvable. And you know why no one thought about it? Because no one figured out how to monetize taking care of patients other than treating their illness. The other surrounding was not important for any investors to get in. And like I said, the system was if the hospital is making money and the doctor is making money, oh well, so all go home and move on. So access is an issue. the redundancy and duplication of testing and paper filling and whatever is an issue for the paper. Of course, wait time and on average, it's 48 minutes waiting in the doctor's office. And you know what? If you call it waiting room, the patient is going to wait in it. If that's the mentality, if we put the chairs like, it's a train station and call it waiting room, you're going to wait in it. If you call it a reception in the lobby and whatever it is, no one wants too many people in the reception in the lobby. So you're going to get them in the room faster. So how about the physician, especially the primary care providers? Do we have any of the payers represented here? Good. So in 1998, I sat down with Tony Marlin and John Bunker, and we signed our first HPN contract. Our cap was $18 to $20 PMPM back then for the commercial population in HPN. 1998. 2025, how much do you think the cap for the primary care is today?
18, 40.
18. The lower end of 1998. And then they complain and says, like, how come you're not doing a good job? You're paying, can you pay your people what you paid in 1998 and expect them to exceptionally perform? So as a result, they're saying we're going to make it on volume. So I'm going to see 40 or 50 or even more patients per day so I can make it up. And what being compromised is patient care, patient experience, clinical outcome, because outcome is irrelevant. As a matter of fact, one of the worst things ever was this P for P or payment for performance and quality, and it turned out to be is a checkbox. How many boxes can you check? And if you do that enough, I'm going to give you a bonus. It's not clinical outcome. So for a hypertension patient, the quality index that I can earn my bonus on is that I documented 90% or more their blood pressure measure when they come to the office. Not that the blood pressure is improving, but it's that I documented the blood pressure. And the reason for that, I understand how it started. So in Thomas Jefferson School of Medicine, which is David Nash is the father of all the quality, they had Thomas Jefferson School of Medicine had a hypertension clinic, and when they audited 5 years later, they found only 50% of patients with hypertension that went to the clinic had a documented blood pressure in the chart. So that's where they came, that you have at least a document of the blood pressure. But if you ask me, you need to get the blood pressure not only documented, but below 140 to 70 or 80, at least 90% of the time. But neither here nor there. When the doctors had to rely on volume to survive, everything else got compromised. When they got so frustrated, they sold to the hospital, they sold to Optum, they sold to the next whatever. Yeah, and it results into even more professional frustration to the primary care, more lack of independence, and deteriorating outcome. Because now they moved from seeing 40 patients to, oh my God, I can only see 12. You're paying for it. So I'm going to only see 12. Well, guess what? The access even worsened in that time, because when I'm volume dependent, if they called at 4 o'clock and said, come on in, I'll wait for you. But when I'm not volume dependent, after 2 o'clock, you cannot schedule anybody. because it's the mental health of the providers. But it's the burnout and attrition. I think 23 and 24 had the lowest medical school or residents, graduates that enter into primary care on record. Because I'm going to work, be a hospitalist, I'm going to work, be in large hospital system or insurance company. They want to be independent. They want to be independent not only because they're entrepreneurs, but they want to be independent because they want to take care of patients the right way, or at least the way that we're trained to do it. So as a result, in Nevada, we had our worst access in the last 2 or 3 years. Even if you adjust it for the pandemic, we still have our worst access rate. And we actually moved up a little bit by 2017, 18, but now we're back into, if you rank on access alone, we're number 49 or 50 among all states. And the specialists are not that much better. They are either sold to the Optum, to the Intermountain, to a private equity firm, to I don't know if a hospital system here are acquiring much practices, but they're losing their independence, they're losing their ability, they're resorting into a fight with the hospital for subsidy and calls payment and whatever they can generate passive income from. And then they all got into injections and infusion and diagnostic in their offices. So the offices turned into factory instead of a true... there was a principle that I always said, the first step of solving any problem is recognizing that there is one. So if we continue to dance around the issue, says, we're improving, we're doing great, everything is fine, let's just go to sleep and hope for a different outcome tomorrow. It's not happening. The specialists are fleeing town. The primary care are splitting their presence between refugee hospitalists or a primary care office that want to see 10 to 12 patients a day. And the access is deteriorating and the outcome is deteriorating. And if we continue on that trajectory, in Las Vegas, Nevada, Clark County, we will have the worst clinical outcome on 51 states again. And in behavioral health for children, when you have a problem, it says it's either you're going to talk it out or act it out. So that's the principle. So the opposite in healthcare problems, we talk it out. We don't act anything. I went to the Nevada Healthcare Forum every year since it started 18, 20 years ago, something like that. And we talked about the quality, and we talked about structure, and we talked about the patient, and we talked about the payment for the doctors and the payer, blah, 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 blah. Nothing ever changed. United buys Sierra and Pacific Care, and again, you have one 800-pound gorilla, and the rest would follow. Everybody is in managing medical costs, which is appropriately running, not appropriately, it's accurately running out of control with the high single digits increase year over year, every single year. It's not sustainable. But the only tools that has with the payer, whether being self-funded or fully insured, is a unit cost. going to pay the doctor less, I'm going to pay the hospital less, and whatever I can get squeezed, and the rest of it will run through prior authorization and denial and so forth. But we want to do something different. The hospital has not escaped the challenges as well. The reality is their operation expense, especially under the pandemic and the tight labor market, soared. They now pay millions of dollars in subsidy to the physician groups to provide call and coverage. And they're having to compromise, whether they want to admit to it or not, the nursing staffing ratio to what would have been a safer and a better outcome environment. So in 1999, I don't know if you remember or not, Dr. Berwick presented the famous presentation about the quality, and that year the Institute of Medicine issued a report, says to err is a human, and they counted 100,000 preventable deaths in the hospital every year. And they started the Leapfrog and others about preventing 100,000 deaths. That was the goal. They put safety in place and infection control, and all these steps were put after that famous initiative from the Institute of Healthcare Improvement in Boston. Yeah, and I encourage you, go search in the YouTube, Don Berwick speech in 1999. It will move you. But it didn't move the number of preventable deaths in the hospital. Last year, the Institute of Medicine issued a report, and it's 120,000. 120,000 preventable deaths. They're not talking about the 95-year-old grandma that went in and they're talking about preventable. Number one medical error in the hospital today in 2025 is operating on the wrong side. After all the steps that we did, there is an average 4 medication error per patient per hospital day. So the hospital has not escaped the pressure. They're under scrutiny. They're under pressure financially, and they're struggling to align with the physician because the physician perceived inappropriately, I might say, perceive the hospital as the competition or a pot of gold. I'm just going to go and ask for more money legally. So even the payers facing challenges. Even the United of the world get to see their company value drop by 48 or 50% over the last few months. Yep. Having changed the CEO, bring Steve Hemsley back, and struggling. It's the cost is out of control, and the good old failing ways of paying the doctor less and trying to squeeze everybody with the unit costs and try to create a prior authorization platform that deny enough claims. And look, I'm not saying every claim that we submit as a physician or hospital is appropriately measured and medically necessary. A lot of the time it's because I don't have access to the chart. Patient had a CAT scan last week. I don't know what it showed. Much easier to me just order another one. And some of it is just waste. Some of it is abuse. And we have to admit, some of it is fraud. Knowingly ordering unnecessary testing. So the payers got their challenges. They're not aligning. So the premise of the clinically integrated system of care that we align the social, moral, and economic incentive of all those three elements. The patient, the hospital, the doctors, and the payers. If we are able to align the social, moral, and economic incentives, the patient is going to walk into the room with the trust that the doctor has got his or her best interest in every step of the way. And if you do that, if I go to the hospital and I know that the hospital administration and the staff got my best interest as a patient and as a doctor, I go there, stick to it. So how do we do that? What if, so let me pause here for a minute. I'm going to ask Carla to come up, and as we draw this clinically integrated system, it's one of her brainchild, as well as the rest of us, and it's very close to becoming a reality. So Carla, why don't you come up here?
Supposed to tell them what we're going to do?
Yeah.
All right. Well, good morning, everyone. Carla Perez, for those who don't know me, I'm a regional vice president with Universal Health Services. I oversee all of our hospital and ambulatory operations across the state of Nevada. And as Sherif said, we've been talking for many, many, many years about building a new healthcare delivery system that really focuses on what I'll call the triple aim. Many of you have heard of the triple aim, improving access, increasing quality while decreasing costs. And that's where we're really focused. So the idea behind the clinically integrated system of care is to align physicians, hospitals, post-acute providers as well, along with the payers, and create a system where we all communicate together and really make it seamless from the patient's perspective. So it really is an attempt to differentiate care from a patient's perspective. So a patient will feel much more comfortable accessing a system that they feel comfortable in because we have their medical record, we know who they are, they arrive at the hospital, we already have them pre-registered, we know who they are, we have their information. We obviously need to validate that it's still accurate, because some patients move or change their insurance, whatever the case might be. But having all of that information already in the hospital, that starts to build trust, right? It's kind of like having that gold card when you go into the VIP lounge at the airport. They know you, they recognize you, they have the card, they just welcome you in. That's the idea of what we're creating as well. But it starts also in the primary care office, where, again, they start with the information, they will gather all the data, that then gets shared to the hospital, gets shared to the post-acute provider as well. Anything else you want me to touch on?
No, that's it.
Okay. Thanks, Sherif.
So before I go on, I want to recognize a couple of people that really made the difference in this community. One of them is sitting right here, Ernie Lippman, who gathered this group for how many years now, Ernie? 15 years that we got together, and I think hopefully today have a birth of a new idea that will make a change. Also, Bruce Wiggins, who has been helping me putting all these thoughts together, and he's been a leader in the community for a very, very long time. So thanks, Bruce, for everything. And Kathy Silver, who gave me my first job, so
And your second job.
and second job, and the current one. So what if we have one chart for the patient that grab the data from the primary care, from the specialist, from the hospital, from the skilled nursing facility, from the rehab, from the home health, from the pharmacy, from the diagnostic imaging, put it in one chart? And what if you're able to use an AI to query that chart and says, when was the last time that patient had a CAT scan? And what was the result of that CAT scan? And do you have the images of that CAT scan? And what if I can ask the chart using an AI, give me this last 6 blood pressure and put them in a curve for me. So they give you the last documented 6 blood pressure, it's going up, it's going down, it's stable, changing. Same thing with every lab. What if when Mrs. Jones showed up in the ER doctor had access to 5-year history of her charts? But he or she, they don't have to go knock through the chart. They can ask the chart and say, does she have the directive? Whatever you need to create the chart, last CAT scan, last MRI, so you don't have to waste diagnostic resources and log the system with unnecessary testing. What if, when Mrs. Jones goes from Dr. Calderon to Dr. Smith, a specialist, her demographics information is already preceded, populated, and ready for her to, or him, to say, yeah, that's me. That's the address, that's Social Security, that's the insurance, that's everything. I don't have to sit down and fill up 34 pages anymore. What if you end up in the hospital, they have all your data already in there? If you're scheduled for, I remember last year, my mom had to have a back surgery. It was a disaster. I mean, look, 2 or 3 hours or 4 hours of my time is a lot of time. And I'm sure out of everybody's time, but it's so frustrated. I have to go to the day before, spend almost half a day inside the hospital registration or admissions or whatever it is, to fill paper upon paper upon paper and then sit down for an interview to ask you about the same information again. What if my mom just had to show up for the surgery early, the morning of the surgery, all her information in, she just signed an informed consent and go on. What if we're able to negotiate with the payer a meaningful increase of the primary care for a guaranteed access, same day for emergent, 3 days for urgent, 14 days for routine visit. And every patient will be seen, that panel to me, will be seen within 30 days from them starting being my patient. I'm not gonna wait for them to get sick. I'm gonna reach out and say, come and do your annual physical. Every patient will have an annual physical every year. And like I said, the true value base need to accrue for the patients first, everything else would follow. If I improve the patient's clinical outcome, not the check the box, but the clinical outcome, the blood pressure is lower, the total cholesterol is lower, implementing all the diet, lifestyle changes, training and education, and being a health coach for the patient when they're healthy to keeping them healthier longer. What if the hospital and the physician network is on the same side? What if the hospital and the physicians and the payers are on the same side, all of them aiming to take care of patient? What if the world does not have a prior authorization anymore? So stay tuned. I think we're 90% there. We have secured commitment from the investors and Rubicon founders to invest into building this technology. We have identified 2 technology platforms that both of them can deliver on the what-ifs that we just discussed. And and we're hoping the next step will be that you'd have all this on your phone as a patient. You'll have the chart, you'll have the shareable demographics that when a patient says, can you fill this 34 pages? No, I can't, but here it is. You can have my information. So we're hoping toward the end of next month, early the following, that we would have a citywide or countywide, maybe even statewide presentation for that system, that dream will come true, that you all going to be proud of, and you remember that you were part of that birth of that change. So anyway, I thank you. And
Sherif, I have a question.
Yes.
Is it one software system and everybody's going to integrate into it, or are you going to create conduits from all the EMRs?
Yeah, we'll create a conduit from all the EMR. So the two things happen. The technology of interoperability is advanced significantly, and the regulation, TAFCA regulation, required every certified EMR to have an API access, so you can have a virtual information superhighway, basically, that interconnect these data and integrate them into one chart. It exists, just no one paid attention to it.
It's a dream. I mean, it just isn't even there. Yesterday, Clem and I are living in an extended, I guess, aging program. And a lot of people call me and say, where do I get access? I'm walking across the street to Pavetti's building, to one of their primary care modules. That's not too good. And a very nice lady, and I said, here I am, I'm great. I'm a really important person. Can you tell me how fast I can get this new patient in?
She didn't bring her ID with you. She didn't know who you were.
About 6 months, we were 6 months
Yep.
to get a patient integrated into the system. Now, how are we going to jump the queue here? How is this ever going to happen? Between what I described, you hopefully will be able to put in place.
Yes, it's not going to be easy, but for the first time, when Carla and I met with United folks, Kim, first time, I was being prepared to be thrown out of the room or like get stuff thrown at me. She didn't. As a matter of fact, the second time, she was even more enthusiastic about that and investing in it. And she had one condition. And I thought, like, she's going to ask for exclusivity, which is something that we can't. I mean, it's almost unethical if you have this solution. You say, I'm going to give it to Mr. Jones because the insurance company has exclusivity and Mr. Smith can go stand in line. So it's going to be a practice-based. It's not going to be payer-based. Here,
Just tell me who to call.
Yeah, here ask, I want to make sure that all my patients are included in that program. No differentiation between HMO, PPO, exchange, or Medicaid. I want to put them all into that program. So I called the guys from Aetna. It took them about 38 seconds to answer my text, and we're scheduling time, and they're going to engage into it. I can't get hold of the folks in Anthem, but Carla's going to help me get in front of Mike Murphy. Then the self-funded is going to be the next. They're struggling with increased cost, lower quality, same thing with access. They're having to pay it and create a narrow network, which is counterintuitive to access. So stay tuned. What else? Yes, sir.
I don't know if anybody knows, Sherif, we're probably in this country spending, 18, 20% of our GDP on healthcare.
Yeah.
At some point, the nation can't afford it. It's kind of like the school districts keep throwing money there with no results. So you hit it on the head. You got to do something different, even though it's not going well now, and it's going to be a very difficult task. Ernie is correct, but you just can't sit around. You got to do something.
So I lived through this when Healthcare Partner acquired Fremont in 2009, and the access was horrible. You stand in line forever, and you cannot get a doctor appointment for weeks and weeks and whatever it is. And then we implemented value-based capitation and put the physicians on salary very close to what they were getting under the RVU and an incentive for access. Well, guess what? Their schedule dropped 33% and their access increased by 50%. Because before in a volume-based, come back next week. In a volume-based, you have a lab test and the doctor would like you to come in so he can tell you the lab test, and the doctor walks in and says, Mrs. Jones, everything's great. Like, couldn't you have just sent me a text with the like thumbs up emoji or something? So it is aligning social, moral, and economic incentive. When I'm telling you, the access is self-induced. The patients come back too often unnecessarily because they're the only source of my income. And you can't blame me for it. And as a result, my schedule is full because I made sure it's full. It's one of my purposes in life is to have a full schedule for the next 6 months. So I think the most important platform for the clinically integrated system of care, which we're going to unveil the name soon, when they tell me what it is, it is that alignment between the patient, the providers, the hospital, and the payer, where we don't have to play cat and mouse anymore. Yes, ma'am.
I just want to ask, I think it sounds great, Sherif, and I think it's something we've been trying to do for about, 4 years now?
Yep.
I think it's close, I think it's a great idea. I think the problem is going to come, and I'll speak from a self-funded perspective. People show up everywhere. Their benefit plans allow them to go anywhere, any emergency room, and then once that happens, this all goes to crap, I'm sorry.
Yeah.
Because you get into somebody else's system then. And then you start all over. And the big problem is the individual self-funded plans don't want to mess with their plan designs to limit access because it makes them unpopular.
Yep.
So if you're a union plan or an employer, large employer, you don't want to have benefits that limit your people for where they want to go. And to me, that's the biggest hurdle.
Yeah. So
This work.
two things. Number one, we believe that the patient, once they accrue the benefits of being in the network and having the interconnectivity and the information and not having to fill different paper, and when I get to the hospital, they know all about me and all my demographics and all the informations and healthcare directives and so forth.
But you're talking about educated patients. You're not talking about patients with lower socioeconomic status and lower degree of education.
Maybe, but I did say I think they're intuitive more than we think. They believe that,
They weren't the culinary, I can tell you that. They were financially oriented,
yeah.
financially incentivized.
So if you create a financial incentive for the patient to be in that network and realize then they're going to move. There's some of them is going to move for financial incentive. Some of them is going to move for the convenience and the integration platform. Some of them going to move for the technology platform, a younger, more educated population, which is we have more and more of it today, especially the younger population, regardless of their. So everybody has an iPhone, whether being sitting in a palace somewhere or sitting on the corner of the street. They have an iPhone and they know how to use it. And look, the older population are getting more and more savvy. My mom, she's 83, God bless her, and she's using the iPhone. She communicates with it, and she posts on Facebook and Instagram and whatever, more than I do. So same thing with my mother-in-law. I'm sure you're all experiencing the same thing. So It's a time to make the edge of technology serve the patients and the healthcare system. I remember when they introduced the EMR, and it's going to be the best thing since sliced bread, and going to improve efficiency and reduce costs, improve quality, blah, blah, blah. And on average, your EMR increased the time per visit to 13 and a half minutes, on an average. You all heard about the pajama time or pajama EMR, which is you go home, you have dinner, then you sit down on your computer and fill all the charts because it takes forever. So I think we have a promising and confident group of physicians and hospital administration that they're behind it, they're investing into it, and I'm telling you, the investor is not going to put their money if they don't believe in it. The hospital is not going to invest into it unless they believe in it, and the doctors should be committed as well. And so far, we've had a very committed group of physicians to do that. Yes, ma'am.
Ma'am, I'm Dr. Forte, primary care. You're talking to me directly. So one is, I think, brilliant. When we get to 25, we'll be able to get Fulton and Diego to recruit some physicians to come to Nevada, so not 50. And secondary, I did a study on technology, and up to the age of 80, the 65-year-old and above use it as much as the 65 and below, and it drastically decreases after 80, other than your mom and my mom. And so I think this is a brilliant idea because it'll keep me boots on the ground. Thank you.
Great.
You know, lots of people said ACOs weren't going to go. My good friend Mr. Lidman, 12 years ago, harassed me. And look at them now. We got more ACOs by 2030. Most have done quite well here in town. And by 2030, CMS wants everybody to be in an ACO. So these things, it's going to be difficult and it's going to take some time, but clearly I think we just can't spend this much money on the gross national product.
Yep. So I think officially they abandoned the goal of having all Medicare in 2030, but privately says, how can we make it by 2026 or 27? Dr. Oz, in a private conversation, said, I want everybody in ACO. I saw the data, and it's if you look at the trajectory where it was going and where the healthcare costs today, it would have been much worse if it's not for the ACOs. So everybody in the administration currently believes in the ACO model. They just need to figure it out and how to generalize it.
I'm curious, on the legislative front, because there's a bill right now that is looking to reduce interoperability. They're trying to push us back to QHIN standards.
Yeah.
So you have some legislators that I've engaged with, and I have told them, QHIN, you're taking us back 10 years as a community. We're already in the Wild West of medicine. They are very insistent on this is the direction they want to go because those are the federal standards, where every other state's pushing towards health information exchanges, and they're pushing towards more interoperability. Have you gotten any resistance, or have you spoken to any legislators regarding this? Because that's where I find a giant disconnect.
I haven't, but we should probably address that legislative, because I could not imagine once they see the benefits, why would they put a regulation to set us back?
So the follow-up to this, there's people that are skeptical of centralized repositories or patient information and bringing it together. Which to me is odd because every single piece of technology is pushing towards communication and being able to have that information. And in healthcare, some believe that we need to keep everything fragmented or it's easier that way. For me, after speaking with people, sometimes it's a lack of understanding of what a health information can do or these repositories can do, especially now with the advancement of AI, being able to track what patients' health looks like over time versus what a QHIN does, which is just basic output of information. Correct.
So I think once the patient experience, you will have a pull strategy from the patient because they're never going to go back. If the patient, look, I do my annual stuff. I have an app from the lab that get my lab results, and an app from Deseret to get my diagnostic, and an app from the doctors to tell me, and an app from wherever it is. Can you imagine an app that combine all of these? And where all my chart is in my phone or my whatever device. Not only that I have it, but I can share it with, so if I ended up in Chicago and I have to go see a doctor and they're gonna ask us like, here it is. My 5-year history of all the labs, all the diagnostics, all the physician notes and so forth. With the AI capability, that's even gonna be more, yes ma'am.
I would just clarify that the intent of the bill that's open right now is not at all to prevent interoperability, and the regulations just got set a few months ago. So I don't think it's the intent to set any exact tenures, but to help move forward and to allow the patient to have control.
Well, the road to hell is paved with good intentions. So, so we might have the good intent, but we have to sit down and apply it. And look, legislators are not going to solve this. You know, I would respectfully ask for legislators just go home early and leave us alone. Let's figure it out. I mean, I think focus on waste and fraud and abuse and all that stuff if it exists, but don't legislate how we can communicate with the between EMR, and if the patient want it and the doctors are able to provide it, I would leave it alone.
Yeah, and it doesn't do that.
It doesn't.
The bill does not prevent you from having that.
So it's legislation name is leave me the fuck alone. Yes, sir.
As one of the local federally qualified health centers, which treats a significant portion of primary care, especially underinsured and uninsured.
Yep.
What ICE, and it's going to obviously increase with Medicaid cuts that are coming down the pipeline. I think tagging on to what Diego was saying, I think I see one of the barriers. Believe it or not, you would think not, but it is one of the barriers is patient participation in all of this, and they are adamantly saying no. And I think education in that portion, especially for the population that we serve, which you would think it wouldn't be, but it is. It's a huge barrier, which we work on every day, explaining to them, look, you're going to be able to go to your hospital, you're going to be able to go to your emergency room, you're going to be able to, and have that record accessible, but that's a powerful no that we get in our area.
Look, I don't think the system is going to resolve all the ill in the healthcare system, but if I can hit 80% of my patients are in the same hospitals, are in the same skilled nursing, or the same home health, and that information is following the patient. I mean, right now, the patient follows the dollars. Let's just be, they don't follow information they follow the dollars. Where I put it in if the hospital is paying me a high subsidy or whatever it is, and I'll send it to my cousin that has the diagnostic center that takes me out for dinner. And let's be honest. First step, solving any problem, recognizing there is one. Right now, patient follow the dollars. We want the other way around. We want the dollar follow the patients. If you take care of the patient, the dollar will follow, not the other way around.
With the yellow pages. There's no yellow pages anymore. Please tell me what I tell this patient.
I think
Find access to somebody.
we exceeded our allotted time.
One number, two numbers.
Yes, ma'am.
I just have one more question. I'm curious how patients will find out about this system and which practice actually belongs to it.
So we are going to do a big blitz marketing branding, introduce that to the community, to the physician leaders, to the, and we're hoping more and more physician of the
I'm not talking about physicians, I'm talking about patients. Let's say if I don't have a PCP, how will I find out that you have this system? I can, you know,
yeah,
become your patient.
we're putting together a marketing campaign. I think it's, we're debating is it what if or you deserve better. So there will be, we know the audience is our patients first. Thank you very much.
Thank you very much, Dr.
Thank you.
Ladies and gentlemen, thank you very much. Great to Rubicon founders. If we can get a round of applause for Rubicon founders, which helped to pay for everybody's breakfast. We'll get everyone a little bit of time to make some mingle for those that can stay and hang out. Thank you very much. And the next one will be in June. I will send that invite out. Thank you very much.
Thanks, Sarah.
Absolutely. I'd like to talk to you.